Good afternoon, everyone. I'm Raj Rohatgi. I'm the Associate Director for Basic Science at Stanford Cancer Institute. And on behalf of SCI, I want to welcome all of you to our Breakthroughs in Cancer seminar series today, both all of you who are in person and on Zoom. We're really lucky to have as our speaker today Dr. Lorenzo Nardo from UC Davis. He's the Chief of Nuclear Medicine there, and we'll introduce him in a few minutes. But I want to say a few words about the Breakthroughs in Cancer seminar series. As many of you know, it really is our flagship seminar series where we try to bring people from across the world who are thought leaders in various areas of cancer science. They spend a day at Stanford meeting with faculty and trainees and telling us about their most exciting research. So I hope that you continue to support this series. So now I want to turn the mic over to Dr. Benjamin Frank to introduce our speaker for today. Dr. Frank is in the radiology and nuclear medicine departments. Ben.
Thank you so much. So great to see all of you here and those on Zoom. Just a couple quick notes for today's seminar format. We'll have 45 minutes of the lecture and then 15 minutes for questions and answers. For those in person, please join us outside for the reception afterwards. Now, it is my distinct pleasure to welcome Lorenzo Nardo here. Dr. Nardo is a professor of radiology and Director of Nuclear Medicine and Theranostics at the University of California, Davis. He is also the co-director of the Explore Molecular Imaging Center there. Dr. Nardo's research sits squarely in the translational space, bridging basic science and engineering with advances in clinical imaging and new cancer therapeutics. Much of his recent work is centered on total body PET and the advantages that long axial PET brings to understanding oncologic processes. And hopefully he will tell us all about that today. So with that, welcome Lorenzo, and please take it from here. Thank you.
Thank you. It's an honor to be here. And so first of all, just before starting, we just like to acknowledge formally my disclosures. These two slides, one is related to my institution and one is more personal. So the story of long axial field of view PET-CT is pretty long and full of ups and downs. And at the end was a story of success, but as all the great success, there were a lot of ups and downs. And I didn't come on board till 2017, but actually this story started way before, even before I was born. And we'll start with Dr. Jones, and in the UK, we'll start with many other people. And I just want to start this lecture with this paper. Is from 2017, 2018 when it was published, and it's pretty much when I arrived and I was on board on the project with UC Davis. So before me, all the consortium, the Explorer Consortium, was responsible of all this new invention that is dramatically changing the field of PET-CT. So we have Dr. Cherry and Dr. Badawi, they're from UC Davis. We have Dr. Karpel from University of Pennsylvania, Dr. Moses from Berkeley, and then Dr. Jones and Dr. Price from the UK. So what is about this invention? What is in that paper? So first of all, they clarify what is the concept. We are used to have a field of view in conventional PET-CT scanner about 15-30 centimeters. And these scanners are wasting a lot of signal. There's no way for us to capture the signal that is within the patient. And so the concept was to build around the patient all a larger scanner with many more detectors to capture all the signal or most of the signal coming from the patient. So the concept initially changes the axial field of view from 15 to 35 centimeters to almost 2 meters. So pretty much 98% of the population can fit in the scanner's whole body, head to toes. So by doing this, there's an increase in signal collection efficiency. You can pretty much everybody, I believe, is familiar with PET. You inject something in the body, something that is radioactive. This radioactive material distributes in all the body, and from the body starts spreading the signal. And so if you cover all the body, the more you cover the body, the more you detect the signal. And so that's all the concept behind this incredible invention. It's not just signal collection, so how much signal you take, but also the spatial resolution. Spatial resolution of this, the specific one in the figure now, but most of the long axial field of view scanner is pretty good. Is between some they go as low as 2.9 millimeters. So in the specific one is about 3 millimeters. But if you couple together signal collection efficiency and spatial resolution, you can image better. You can image faster, later, with low doses, and some of the scanner can do all body together or a big portion of the body. So in 2019, we can see the first scanner with this capability was installed at UC Davis in May 2019. But shortly after, many people have been talking about and thinking about what is the best axial field of view. You remember in the first slides was a 15-35 centimeter, what we used to have before the conventional PET-CT scanner. Now, what is the best one to do? Like the Explorer Consortium decided 194 centimeters, but why 194 centimeter? Many other people have different opinion. So there are people in Penn, they have different opinion. People in different companies have different opinion. However, after the installation of the first PET-CT scanner, long axial field of view scanner at UC Davis, there were many of these scanners that came to life. And to answer the question of what is the best or most perfect axial field of view that we need. So to respond to this question, different company had different answers. And some decided that was slightly above a meter. Some was a meter and a half. Some almost 2 meters. But so what is actually this challenge came up with many more scanners to be installed across the world. So from the first one, as you can see now, there are many, many more, and each of them with different axial field of views. And many more are actually being built. These are the 3 that are FDA approved or clear. But however, there are many other scanners that, as you probably know, are known as the J scanner, like from Krakow. It's all a plastic device invented there and being developed there. And there are many others that you can find in the literature. There's a walk-through scanner now also that people are talking about, and there are first simulations. So since many more institutions were acquiring long axial field of view scanners, we felt like a little bit of definition, no longer a physics definition. Physicists have been saying, you need this arithmetic, these models, you need this specific calculation. But as clinician, what do we need? What our patient needs? So what is the axial field of view that they need? So all the PET-CT scanners can pretty much scan all bodies, most of them at least. So we divide in short axial field of view scanners and long axial field of view scanners. The short axial field of view scanners are scanners that can image all the patient, but they need either multiple bed position or continuous bed motion, like on the top of this image. And then we have a long axial field of view scanner. This long axial field of view scanner can always detect in at least 90% of the population most of the portion of the body. So we discuss and we came up with an idea that more than 100 centimeters you can define a scanner as a long axial field of view, because you can have the most frequently obtained oncological evaluation, which is eyes to mid thighs, in about 95% of the population. And then we decide to talk about total body PET when this long axial field of view is greater than 188 centimeters, which includes in more than 95% of people head to toes. So what is the optimal axial field of view? There's really no an answer. As all the problem of science, usually the answer is more complex than what we think. So it depends on the institution. There's not really an answer. Like many institutions with a conventional PET-CT scanner can fit all their needs and be okay with that. But what are the needs on an institution? Are research needs, are clinical needs, or somewhere in between? So, for example, if you have a facility that is maybe in a periphery hospital with less resources, but needs to get at least 5-10 patients a day scanned, you can also probably, with a short axial field of view, like a scanner that is a little bit usually cheaper than a long axial field of view scanner, just because feel about how many detectors you need to buy in order to get a longer axial field of view scanner, that can get the work done. But then if you're in a larger center and you need to do more scans, you need to have probably a longer axial field of view scanner, which allows you to scan more patients faster with less dose. And then if you're a research institution, what is your answer to that? What do you really need? So it depends on what are the research institution needs. Some institution wants to do cell tracking. So some institution want to do drug development. Some institution wants to do they want to just see all the system from head to toes to see if what is connected to what. Other institutions are we just need to scan really, really fast, and we have 100 patients a day to scan. And so what is the best scan for them? So for example, if you really need to have just a high throughput of that, probably a scanner is more than 100 centimeters is more than enough. But if you want to do analysis, kinetic analysis, whole body kinetic analysis, develop new drugs, probably the best scanners is a scanner that has an axial field of view of 2 meters or even longer. So there's really not an answer to that. And in answer to this, each institution has specific protocols. So the injected dose, the uptake time, the stun length is pretty much different between institutions with long axial field of view scanner. Nowadays, after 5 years that these scanners, 5-6 years that these scanners have been implemented, there have been some homogeneity or going towards a model more homogeneous models to use these scanners, but still there are very much variability between institutions on the voxel size used for reconstruction or the number of interaction, the PSF on or off, smoothing or no smoothing, quality of imaging, are you using, how much contrast to noise ratio you want, what is the image resolution you want to see. So based on all of these, we can have different outcomes. We can have a clinical impact. Maybe you want a longer scan with a relatively high dose that depicts each single small anatomic or pathological structure. Maybe you just want a lot of patients in and out of the scanner just to make sure that everybody has access to care. Or maybe you have just some specific population, such as pediatric population or pregnant women. And at this point, you need to make sure that the radiation dose is lower than another scanner, because these populations are more sensitive to radiation. And so there's really not an answer, and it's based on institution. This is just a variety of institutions with a long axial field of view scanner, some from Asia, some from Europe, and from the United States. And you can see how pretty much the acquisition time is much lower than a conventional PET-CT scanner. We scan, probably UC Davis is one that use the longer acquisition time, about 10 minutes, but most of the other facilities use less than that. And the uptake time is pretty much the same for everybody. It's about 60 minutes for FDG, which is the most commonly used drug at this time in PET. And the injected activity is much lower than the conventional PET-CT scanners, but is relatively similar. You go from 2 megabecquerel per kilos to 3.57 megabecquerel per kilos. So no matter which scanner you use, long axial field of view scanner, the one present in the market, FDA approved or clear, are always great, and the image quality is can be seen in this selection of tracers from FDG, Dolotec, fluorcyclovine, sodium fluoride, and PSMA. You see how exquisite the image quality is. So I would like to start thinking about imaging better. What structure you can see? So if we compare a short axial field of view scanner on your left with a long axial field of view scanner on your right, you see how this small anatomic structure known as ganglia are better seen, actually are seen only or distinctly seen only on a long axial field of view PET scanner, just because probably spatial resolution is higher, and mostly because the signal collection and the signal coming from the patient is much higher. Then what you can use this information, okay, we can check for the small anatomic problems, but how clinically this can be used. So sometimes you are doing surgery that are not necessary, and you're just giving patient more pain than what they are needed, because actually the cure should be a systemic treatment rather than a treatment that is localized, such as a surgical treatment. So for example, if you see better metastasis, as in the first line, you can see this left posterolateral wall nodular metastasis from lung cancer, or if you see this intramuscular metastasis on the second image in the right intramuscular proximal thigh, or these retroperitoneal lesions, that can be changing management, and maybe some patient will not need surgery at that point. Maybe they need neoadjuvant therapy in front, or maybe they will need just systemic therapy rather than a surgical procedure. And then, does it change patient management? Yes, it changes, because we have a lung cancer clinical trial that was started a few years ago. In this clinical trial, we have a patient with lung cancer, staging lung cancer, that were scanned, were injected with FDG, 10 millicuries, like similar to most of the institution, and were scanned first on a long axial field of view scanner and then on a short axial field of view scanner consecutively. And then they were assigned randomly to arm 1, where the first scan was a long axial field of view scanner, and arm 2, where the first scan was on a short axial field of view scanner. So we randomized this just for the biology of the tracer to avoid that bias. And we saw that when you use long axial field of view scanner, you are more accurate on detecting metastatic lung disease in the lymph nodes. So the end stage of lung cancer was affected by the modality that you are using. And then how does it change imaging follow-up? For example, this was a case of rhabdomyosarcoma. And so, as you know, most of the people affected are pediatric. And there's really not a guidelines on how to follow up tumors such as this one. And institution and each oncology sometimes have a little bit their own guidelines. NCCN is coming up with a specific guideline soon, but at this point there's no NCCN guidelines for rhabdomyosarcoma, for example. And you see like a conventional PET-CT scanner on the left, obtained right after the end of the therapy. Then a follow-up, since the patient was considered treated or like no other disease, was obtained about a year after. And this was obtained with a long axial field of view scanner. This axial field of view scanner actually shows something there, which is tiny, and it's very hot. And at that point was when we first implemented these scanners, and we didn't know what to do with that. It's just ultra sensitive, or there's really something in there. And so at that point, we decided to do a very, very short interval follow-up, which usually you do not do with rhabdomyosarcoma. If a rhabdomyosarcoma is negative, maybe it takes another 6 months or at least a year to be scanned, if they scan with a PET. However, in this case, since we saw something, we decided to ask the pediatric oncologist to scan very soon. And they scan again, and scan a very few weeks after. And the tumor was really, really much larger, as you can see. So does it change management or change in imaging follow-up? Yes, it does. When you use the scanner, we see that you can change imaging follow-up recommendations. And then see how the quality of the scan can tell you how many of these lesions are treated. So, for example, in this other pediatric patient, you see the metastatic bone lesions that have the metastatic bone lesions are very sclerotic, right? If you use a long axial field of view scanner, you probably can detect all of them with no activity on this sagittal screenshot. And if you go on a conventional PET-CT scanner, these lesions are really difficult to detect. I don't see an area of photopenia there, so I don't know if they're treated or not. Based on CT, they're sclerotic, so most likely probably are treated, but do we know that? Not definitely. But clinically, I believe that if you have this scanner, you can use this type of scan, you can probably be more comfortable about your diagnosis and avoid the patient to come back again if everything is photopenic, right? Or delay the follow-up and decrease the radiation to the patient. Another thing is like some modality, I understand that some institutions have PET MRI. We do not have PET MRI. So MRI is great for bone disease, but if you don't have PET MRI and you do a PET CT, many of the PET CT are very difficult to detect. It's very difficult with the conventional PET CT to diagnose small metastasis in the bone marrow, because bone marrow is a pretty high background uptake. It is about 3, similar probably to the liver background, slightly less than that. And so when you have this such a small lesion, we didn't know about this lesion in this patient. This patient was an adrenocortical sarcoma, and we didn't know that there were metastatic lesion at the beginning. And so in the follow-up scan, when we see this lesion that is photopenic, then this lesion turned out to be a treated metastasis that was not known before they started systemic therapy. And then it's not just clinical, but also for research. These imaging are amazing, I think, in explaining how the difference between conventional PET-CT scanner on the center and on the left side, long axial field of view scanner, are different. So this is a work that was done in collaboration with UCSF, and we injected a monoclonal antibody for labeled with zirconium. So as you guys know, zirconium is really tough imaging with zirconium. Gives you a very big dose to the patient, just 1 millicurie of zirconium gives the patient a exposure of about 30-35 millisieverts. So it's very high dose. You give the patient just 1 millicurie of this of zirconium. Zirconium positron range is not okay. Is not great. Is a poor radiopharmaceutical usually for imaging. However, is the best or one of the best when you want to label any compound for your research. And so, as you can see, the patient was scanned UCSF first after injection of about 0.5 to 1 millicurie of zirconium labeled antibodies, and this is the image that was obtained in 48 minutes. While this one was the image was obtained UC Davis using a long axial field of view scanner within 20 minutes. The day after, when you can also image that maybe there's a little bit different distribution, it's different to observe in the scan, but for sure there was also some decay, physical decay of the radioactive particle. So I think this slide is for any kind of research or anybody using zirconium label antibodies is of great inspiration. Let's move then to decreasing scan length. Decreasing scan length can be useful sometimes. Personally, I found it useful just in a very few occasions, but there's more to explore. So this is a patient affected by lung cancer, and we reconstruct the images up to obtaining breath hold examinations on the left, about 19 seconds. You can see how the more you decrease the time, acquisition time, the higher the noise level is. And however, you can make an argument that even this breath hold examination, like breath hold time, can give you all the criteria you need to diagnose this patient. There's a little bit of noise level that could potentially make some problems, and in terms of the specificity of what you see or the sensitivity. However, you see very well the mass, the right upper lung mass. And some groups are developing some models that are based on breath hold examination, because small lung nodules now can be imaged. And usually PET is not a breath hold examination. CT is, but not PET. And so if you eliminate the breath hold, then you can increase the signal and you can characterize nodes. You can characterize probably nodes now that are about 3 millimeters, while the literature used to say the PET, probably our limiting PET was 8 millimeters till a few years ago. Now you can really go down to 3 millimeters. And another part is like the scan length in pediatric patients. You want to avoid anesthesia, right? So maybe you want to just scan the patient right away, and you want to scan the patient for a very few minutes, and just because the patient will not tolerate or doesn't want to stay still on the scanner. And or you have patients that have metastatic bone disease, they cannot tolerate stay still on the scanner for as long as a conventional PET-CT scanner is longer than 20 minutes. And so you can scan patients in much shorter time and make them more comfortable and probably achieving the same diagnostic quality than a conventional PET-CT scanner. This is a pediatric scanner, pediatric patients that we acquire. And what happened also, sometimes what you can use, because using this, you can acquire in a list mode the imaging. And then you can go back, examine for motion, and just use the fragments that were acquired when the patient was still. And that's another thing you can do when you acquire in list mode with this type of long axial field of view scanners, because all the body or most of the body that you need is already acquired at any time during the acquisition time. And then there are a little bit of sometimes workup we do for our anesthesia patient or our pediatric patients. As you know, some pediatric patients, even if are 6, 7 years old, they are very good holding the scanner. They can go on MRI without motion, without anesthesia. Others, they are even 11, 12, they cannot tolerate, they cannot stay still. So we have a process, a little bit internal process, where we have a child life specialist assessment. They go through the patient records, they talk with the family, they check if probably other techniques such as MRI or other techniques that were they require long cooperation from the patient were acquired, and they make their assessment. We publish a scoring system to assess this patient, and based on this, then there will be a conversation between the radiologist and the clinician, and we explain to them that we can do a scan without anesthesia. Maybe, like if a patient is unlikely to stay still, we can obtain a scan. Yeah, we can obtain a scan for general purposes. For example, you have a pediatric patient, you want to check where is the hottest spot for us to make a biopsy. So yes, we don't need anesthesia for that. You can put the pediatric patient in for 20 seconds, 30 seconds, and we can find a hot spot for you to place a needle in and do your biopsy. But we cannot guarantee you that that staging is as sensitive and accurate as having a patient done in anesthesia. So that's all a risk-benefit discussion that's been made between radiologist and clinician. And from there, we make our decision. And then we have a very strong physicist support. So they go in, they have motion correction software, they apply mini-smoothing algorithms, and they can reconstruct images to make them the best that they can. So optimization imaging through physicist support is also a pillar of our care. And then let's now talk about these other characteristics or features that long axial field of view scanner can have. Is a decreasing injected activity. You can decrease injected activity and get great images. So the Society of Nuclear Medicine and the European Association of Nuclear Medicine were making some assumption about how much is the dose that each scanner, each patient needs to have, how many millicuries, how many megabecquerel you need to give. So we demonstrate very well that with half of millicuries, so about or less than half of almost 15 megabecquerel, you can obtain great image quality in a healthy volunteer person. And then if you, with the 2 millicuries, so about 74 megabecquerel, you can obtain really imaging of great significance in a patient that is a large body habitus. It's like 6'3". And thanks also to Dr. Chowdhury and Abel Alfez for courteously giving me these images. And reducing injected activity is what you want to do in sensitive population affected by some genetic abnormality that make the person more susceptible. Pregnant women, we have a very, very recent publication done from a group from the Netherlands where they scan a patient and the fetus of the patient, I think was a 27 or like a third semester person affected by cancer with a very, very low dose. And they specify that really the dose to the fetus was really, really low. And we have our own internal paper about pediatric imaging where we justify how we can do 0.5 megabecquerel per kilograms in person and no longer the 4 megabecquerel per person per pediatric patient. And then I know you're all specialized in lung cancer, but the long axial field of view opens the door for new applications that you could not imagine before. So when you're low doses, patient that need a lot of follow-up, and maybe for benign pathology or relative benign pathology, like such as rheumatoid arthritis, psoriatic arthritis, now you can use a new tool. You can use a PET also. You don't need always to have MRI. You have also the information that come from other scanner, from another technique against. However, this is a little bit outside, but it means the long axial field of view scanner can be used for more than only cancer. And when you say more than only cancer, it doesn't necessarily mean that you go out of the cancer field, but you might enhance the cancer field, as we will see later on. Delay images is also a possibility. You see how these beautiful images obtain up to 12 hours after injection of FDG, which is impossible with a short axial field of view scanner. The longest they go probably is 3-6 hours, but you can see how the noise level probably is pretty high at 12 hours, but you have a good scan. And then if you feel like, if you check the background activity of the blood pool and the aorta, and the aorta, blood pool and liver, you see how it decreases with the time. And you can see that probably the best is between the 3 and 6 hours. And when the blood pool and the background activity decreases, usually the kinetic of the tumor is different. Tumor washes out less than normal tissue. Tumor retains FDG. And so if the kinetic curves of the tumor is much different from the normal tissue, the longer you wait, the more this difference is apparent and the more you can detect cancer. And with delay imaging time, you can detect other processes, even physiological processes. Before 2019, I was thinking that the gallbladder vicarious excretion of FDG was really a vicarious incidental finding in less than 1% of the people, right? However, after we check the 3-hour scans in multiple people, most of them, they have activity in the gallbladder. So FDG does get excreted through the gallbladder, yes, in pretty much all the population. And we didn't know that. So you can follow biological processes, and and your mind can think about all the other biology processes that you can follow with these scanners and help your patient with cancer. If you wait longer enough, based on the kinetic difference that we were talking about before, you can see better tumor. You see how 60 minutes on the left, you have a staging scan, and then you have a follow-up scan after chemotherapy, and you see that the liver lesions, if based on the 60-minute scan, nobody would have called anything. They were saying that the liver was clean, complete metabolic resolution. However, if you check closer and you do in the 120 minutes, you see that the lesion on the tip of the liver is still there, is still active. And so the tumor was not treated. And so we consider to do a short-term follow-up. Other physicians at this time might consider to extend chemotherapy. However, every time you have a new invention, you need a little bit to rewrite the book, right? Because we are used to the 60 minutes images. What happened when you use the 120 minutes image or 3 hours images, right? We are not used to. All the oncologists, probably all the hematologists and oncologists, they know about the lymphoma Deauville score. So the Deauville score system or Lugano score system, they are based on the relative uptake of a lesion compared to the liver or the liver background or the mediastinal blood pool. So if you wait long enough, we are saying that there's less blood activity and there's less liver background. And then the tumor is more visible. So how do we adjust? How do we use this information now? So if you use a 60-minute scan, is a Deauville score probably 2 or 3 on the mass, the mediastinal mass. But if you use a 120-minute scan, this is a Deauville score 4. And so usually many people, many oncologists, they use these follow-up images to see if make the chemotherapy more intense or less intense. At least some of them, they use the after 2 cycle interval scan to decide on something. And so this is really challenging. So we open a trial for that to check which one of these 2 is more associated with clinical outcome. Because maybe if you wait longer, the Deauville score is no longer a good predictor of that. And so we need to really have an investigation and see what is the clinical outcome. Clinical outcome is what is really should be driving our experiments. And then in research, you can see how you can track cells, you can track immunoantibodies, molecules, and everything. You can see in this monkey, there was a scan injecting 0.5 millicuries again of zirconio labeled antibody for herpes virus. You can see how the images are pretty good quality up to 30 days. So you can scan very far in and you can see pharmacokinetics, long processes that happen, and you can investigate into that with this type of scanners. And then finally, I would like to introduce dynamic total body PET-CT. And dynamic total body PET-CT is a reality that is coming, and we just need to embrace and learn more about that because we still do not know enough. So when you have a long axial field of view scanner and even more with a total body PET-CT scanner with multiple tracers, you can have a lot of information. And when you dynamically acquire, when you don't acquire just a static screenshot of a patient after 60 minutes with FDG, when you acquire really dynamically all the information, you can acquire a lot of different parameters. They have not been used so far, and they are still really, really challenging to us to understand. And so this is a screenshot of a few phases of the FTG, which is the 80%, 70% of our clinical patients are scanned with FTG. You see after injection, it goes into your heart, from the heart is pushed to the lungs, and then it gets pushed back to the heart and to the whole circulation and excreted through the kidney. So if you use just one of these map, like one of these static moments, you have just something of the patient, but you don't have the whole process of the patient. So what should we do at this point? So I think like kinetic imaging allows you to do parametric imaging, allows you to get these maps that reveals you what we don't know yet. And we don't know yet what they correlates with. We know what is the physical principle behind those. And part of the process, for example, the Ki tells you how much is the metabolic rate. And you can see if you use this Ki image, all our radiologists are used to, but you get all these other maps, they're showing you different part of the process. For example, the Ki tells you how much is the metabolic rate. And you can see if you use this Ki image, you can see liver, like for example, these liver lesions, much better, just because the tumor has a higher metabolic rate than a normal tissue. So if you use these images, maybe you see more tumor, maybe you have more information about the tumor. Maybe this image correlates with some marker with some ctDNA mutation that we don't know yet. Then you have also the blood volume. You have the K1 that in this case is kind of a surrogate of perfusion. And then you have other markers. These are just a few of the maps I want to show you. It's like we are used to just use SUV and overlap that with the PET-CT, but now I think we need to really investigate more in these other parts that we haven't done enough before. Before we were using them, but only on a piece of the body, because long axial field of view allows you to see the kinetic model from head to toes or the field of view you are imaging. But when you had the short axial field of view scanner, dynamic images can be done only on that part, and you need to pick your part. You cannot image all the cancer. You need to pick either like lung cancer, yeah, just primary, but cancer is a heterogeneous disease. What is one meth is doing compared to another, nobody knows. And this allows you to really give you the big picture of what's going on with the cancer. And then, I know I'm getting close to the time, but I just want to also talk about a little bit more horizon related to total body PET. And there's a wonderful workshop going on in Paris now. And there's, when you have total body PET, there's so much we don't know. You don't know that there are so many interactions between the brain that are not known yet that we can explore, between the brain and the gut, for example, or between the pituitary gland. You can study pituitary gland metabolism and how that influence all the axes from the thyroid to the adrenal glands and testes and all of that. And so that can be done all, and all this association can be found out. For example, when you put a patient to chemotherapy, the patient after chemotherapy is not the same it was before. There are so many changes. There's chemo brain. Everybody knows about the chemo brain. But that's not just that. There's so many different things that have changed, and the patient is no longer the same person and maybe needs a different perspective, a different treatment, something more that we need to provide. And maybe with this total body PET, you can also have a glimpse into the genetic, and you can predict genetic mutation. You can correlate genetic mutation. We really don't really know enough, and that's exciting because it's a new field. You can find so much more. But at the same time, it's really, really scary because I know that most of you probably apply for NIH grant. And as you know, NIH grants ask us to make public our data sets and send them a lot of data sets. And what we do for the identification of the images is just stripping out the headers. Make sure there are no images, make sure there are no date of birth, make sure the patient are not identifiable. But how can you make sure that a person is not identifiable when you have all these processes that are being given to public, like all these images? You know how is the ejection fraction of the patient heart. You know how much the kidney is doing, how much the liver is producing, how much you can really know a lot of parameters based on the total body PET. And then just in a superficial layer, like you can also see the other part. You can see the body features head to toes. And this is really scary. This is my Halloween posting, but it's really PHI. There needs to be really protected. We need to protect our patients while we are advancing research. And this one of the paper we published with this PET, the spatial resolution is so good, great signal. You get a face like that. You put a little bit of colors, and then you put an AI software. You put online with some AI recognition software from many different types of social media, and you might find a patient, especially then if you know that the patient has a certain ejection fraction or heart problem, or you can always connect all together and identify a patient. And this kind of, again, scary at the same time and being excited. So with that, I would like just to conclude that talk on time. And I would like to acknowledge really one of the major player in the PET in the PET field, that is Dr. Alavi from University of Pennsylvania. They always help us and brainstorm with us and give us a great idea. Dr. Cher and Dr. Badu, they have been great mentors to me, and they invented actually the long axial field of view PET scanner and installed the first one. And then, as this generation is growing and enjoy themselves more and more, we have also a new generation of people. They are producing so great work, and they are the future of PET, and they are improving the field. And we have Dr. Wang, Dr. Chowdhury, Dr. Roncalli, Dr. Spencer, and each of them is focused on something. There's Dr. Wang that is now directing the total body parametric core facility, and Dr. Chowdhury that is our director for imaging research center. Dr. Roncalli is a biomedical imaging school working on perfusion and dosimetry. And she's leading the dosimetry program, and Dr. Spencer is our director of the facility. So thank you all for your time, and thank you also to UC Davis crew.
Any questions from the audience? Please.
It's a great presentation, thank you. I am a question the EGFR PET. What is your think about one day we can use the EGFR mutant non-small cell cancers. Can be staging to use specific PET, non-specific PET.
Tracers?
Yeah.
Dr. Nardo, would you mind?
Oh, yeah.
Can you just repeat the question?
Okay. The question is like some type of mutation, if we can investigate some type of mutation, like for example, EGFR mutation in lung cancer, how can we do that? So the question is already a little bit answered by a paper, a Chinese group. As a Chinese group that have already worked out every time you have a target, you can make a molecule and target that molecule. And they did target already GFR. And so then I'm blanking now on the name of the doctor, but there's a paper where there are a couple of papers showing how the EGFR targeted imaging works, and they use that to do therapy. And that's really a wonderful thing to do. And it's not just that, there's something that is FDA approved that is under that model, is when you use a there's FES, is another tracer they use for breast cancer. So you don't need any longer to biopsy each single breast lesion or metastasis to see which one will respond to therapy with the hormone. Just because if you put together the whole body PET and you put that together with this tracer, you know which lesion will most likely respond and which not. And if it is a heterogeneity, you already know that maybe you need to intensify the therapy or think about something more than just doing hormone-related therapy. But thank you for the question.
Thank you.
Any other questions in the audience? Looks like we have an online question here from Zoom. All right, so the question online is, are there significant differences in QC protocols to check for crystal array detector fidelity between an axial or a standard axial field of view scanner versus the long axial field of view scanners? I'm assuming that there are a greater number of crystal detectors in a long axial field of view scanner and therefore greater chance of malfunctioning detectors.
Thank you for this great question. Fortunately, at UC Davis, we have this amazing medical physicist group that will take this question to the other world and explain everything, but it's really right on spot. You need more QC. Our QC is more frequent and involves more time. So if you have a long axial field of view scanner, you need to do more QC, as was some of the problem already implicit in the question. You have more weight for the system to fail as well, because it's a more complex system as well. The technology is always great and amazing, but the more it's complex, the more are the problem and the possibility to fail. We probably have so all the QC you do are normal on an axial field of view, conventional axial field of view scanner are done. We do longer. Well, just to give to everybody an impression, because otherwise we go too much into the physics world and the medical physicists. So the phantom. You have a phantom usually. When you have a phantom, like is as big as a baby and is this much for a short axial field of view scanner. For the total body PET-CT scanner, is a tube that is this large and is as long as 2 meters. And so you need 2 people just to carry the cube in to do the QC. So that's just how it gets everything to the other level of complexity. And thank you for the question.
Oh, one last question from the audience.
So when PET-CT was invented, it took a really short time before everybody just used PET-CT and no longer doing PET alone. What are the limitations that you see that we need to address now to get this to become the next PET-CT?
So you're saying like a big short axial field of view
for people to adopt a long axial field of view as conventional.
Okay, yeah. So limitation, there is some limitation, especially at the beginning. My major problem as physician was false positive. Because if you're used to see this finding on PET, on your normal conventional PET, you know how to call them. When you have something new that shows you something that is not there on the short axial field of view scanner, the one you feel comfortable, you want to go to, you every night of your call, you read that one is something that scares everybody. So the first few months, we were really very careful on phrasing that. We will not go to biopsy each single, for example, lymph node in the mediastinum when they were hotter. We always, there was a period where all the scans at the beginning were very slow, introducing in clinical practice the scanner, and we review all the images with the oncologist at tumor board. We really kind of thought through about all of that process, and just to avoid the major limitation to me is false positive. Second limitation that is a pros and a cons is like which is a real one. One of the major limitation then is like between long axial field of view and short axial field of view is economical, how much it costs. And then you can see this as and mitigate that because you do more scanners, you do more scans a day, and so financially you may be able to recuperate that. But then on the other hand, there are also problems that they increase this disparity between population and the healthcare that you can provide. On the other hand, you can mitigate that because you can use the scanners to make images on conventional scanners better than what they are. So you can use algorithms based on the total body PET, amazing imaging, any kind of long axial field of view you get. You can use that to improve using AI algorithms images that were acquired on a short axial field of view scanner in more underserved populations, and so that can be used to mitigate also the problem. So one side it gets more disparity, but if you use that the right way, you could potentially also address part of the problem.
Thank you, Dr. Nardo, for that fantastic lecture, and just one more round of applause.